Okay, so today, knee. All right. Okay. All right. So, as far as patient prep is concerned, as long as the patient can get their pants leg to about mid-thigh, you're okay. If they can't, then the pants would need to come off and you could put a shoe over them. I would suggest taking the shoe off. Maybe it could be okay, but sometimes the shoe, if they have a big athletic shoe on, can affect their ability to hold their legs straight. And so just think about whether or not the shoe is bothering you or not. It's not a thing you must take their shoe off, but if you find that the shoe is a problem, take their shoe off so that you don't have an issue with the positioning. Okay? So I'll go ahead and hold her pants leg up. Okay, we are going to be in the bucky for the knee, so I'm at 40 inches to the bucky, and I'm going to use a 10 by 12 lengthwise. Now, this is a little bit different than what's in your textbook and probably different than what you're doing clinically as well. I'm going to put a 5-degree cephalic angle on the tube and leave it on for all 4 projections. Okay? You really do need it for the AP and lateral especially. It's fine to have it on for the oblique, so I think it's easier to just leave it on for all of them. But it helps to open up the joint space on the AP and to help compensate for that magnification of the medial condyle a little bit and get those condyles superimposed. Some places won't put it on for anything, or they only put it on for the AP. The lateral is the most significant one to have it on in practicality, but we're going to do all 4. So I'll do that. I'm locked in transversely. I'm going to go ahead and just line it up with my bucky. Okay. Now we're going to start with the AP. I want my patient just to extend her leg out all the way. This is not a positioning requirement, but sometimes I'll have them dorsiflex just to hold their knee in position so that they don't let it flop out to the side, because it may flop a little bit, but you can't really tell that. And so if you keep it fully extended, that's not a problem. I'm going to put my central ray a ½ an inch below the apex of the patella. And if you put your finger, like here's the patella, and I come down to the apex and then just center over your finger, you're going to be about ½ an inch below. Okay, because there's the bottom edge of it. And then I place my finger and just center to your finger. Now I have the full 12 on here right now. If it looks like a lot and you want to collimate down a little bit, you can. But I wouldn't go hog wild. I would still make sure you keep at least about 3 fingers above the patella. 3 fingers of light. Okay. Collimate in a little bit side to side. Place my right marker. You want to look at where you're centered and make sure you have equal light field on both sides. And keep in mind, just like in doing the lower leg, that you don't clip that soft tissue that comes out medially. Okay? And then that would be your AP knee.
Okay, now since you put the marker right there, in clinic we put it in the on the cassette in the bucky. But
yeah, I like to keep it on the tabletop as much as possible because then you're less likely to lose in the bucky.
Okay. That was my question.
And there are times you can and times you can't do that, and you might have to put it in the bucky. But usually with a knee, you're going to see light on the tabletop. So I like to see exactly where my marker is. But, if you really... Here's the thing. If I've collimated down, you better make sure you move it in far enough to show in your collimation off your cassette. Because you really don't need, unless the patient has a larger knee, the full 10 by 12. Oh, if you need the full 10 by 12.
So in cases like that, it would be better to stick it on the table.
Oh, yeah.
But if you're using the full collimation,
either way, it doesn't matter. But like I said, here's the problem you run into. If you stick it on here and your tape isn't very sticky, and you do this when you're in and out, it can get stuck and move. It can get stuck in there, it can move, it can get lost in the table. So anytime you can see a place to put it on the tabletop, I would put it on the tabletop. Why not if you can see it? I think you're just less likely
to
run
burn out that way too, like at Extreme Pillow they do. I don't know.
In the bucky?
Yeah, if you put them in the bucky and there's not enough light field, like you can see a faint.
Yeah, I would with the knee always put it on the tabletop. Okay. All right, from the AP, I'm going to do the medial oblique. Now keep in mind when your patient is like, oh, okay, nothing. The rotation comes from the hip, so you're going to turn the entire leg in 45 degrees. When I ask her to turn her whole leg in 45, it will bring your leg up off the table. That's okay. Turn me back just a hair. Okay. I'm going to do the same thing about looking for half an inch below the apex of the patella. Make a small adjustment. I'm going to make sure that, again, my leg just looks centered to my light field, and I'm looking for that 45 degrees right here. Okay, that should pull the head of the fibula out from behind the tibia, and that's the point of the medial oblique, to get the head of the fibula out from behind the tibia so you don't have any superimposition. And that's what you should be looking for when you evaluate the image, for the head of the fibula to be out away from the tibia. Yes, the patella moves medially, but this is what tells you you've got 45 degrees. Okay? So that's
And you said you still center it at the half
an inch below the patella. If you want to come up and look too, because you know the light in here is not showing up very well. Let's turn on the overhead lights and see if that recording does work. I don't know if you can see the light better with that. You can see it looks a little.
Yeah, that's the only thing about recording it on those. You can't see the light, but
well, you can't. If I turn down the lights, you can now. But I want to be able to be sure you can see from the other side how the leg is centered in the light field. Okay, you can relax.
And it helps you talking it through because you can hear it. And at least
at least you get. I like the hearing.
But if you don't mind, we can turn the lights off because that does show up a little bit better.
Yes, I like that.
Okay, then we're going to do the lateral oblique. So I'm going to ask her to turn her leg out, and we want to go about 45 degrees. So I'm looking for that 45 degrees here. And again, I'm just checking to make sure I'm centered, half an inch below the patellar apex. And now the tibia goes completely over the fibula, and it's completely superimposed. And the patella has moved laterally. And like I said, when you collimate, just make sure you've got, about 3 finger widths of light for me. If you got really tiny fingers, you might go
So pretty much, as long as you just move your leg, you really shouldn't have to move it.
Small adjustments. You should only need to make small adjustments until you get to the lateral, and then it just depends on how much they slide when you do the lateral.
Yeah.
And you may have a bigger movement.
I think we did the lateral, it should go a little different, but.
Okay. All right, and so the last one will be the lateral. I'm going to have her roll all the way up on her right side, make sure the apron keeps her covered. You have the option with the lateral to bring this leg over or to keep it back. Now, I don't like to bring it over as much because that has a tendency to roll this knee down towards the tabletop, and then you just kind of have to roll the patient back. And this leg has to stay way out of the way. And if they have a very big leg at all, you'll never get it out of the way. But you do have to watch when you keep it back and see this is getting into the light. I'll fix it. But see, like if she doesn't have her leg all the way back, you just got to make sure you keep this other knee out of the light field. Okay? So I want her to flex her knee about 20 degrees. I want to feel for the epicondyles to see that they're superimposed. If I don't think they are, I can roll her back just a little bit. If she absolutely couldn't hold that, I could bring the sponge in. You got to put the sponge way up underneath to help support the knee though. But you're looking for the epicondyles to be superimposed, and then the patella should be perpendicular. Then I'm going to come back, and again, I'm going to be a half an inch below the apex of the patella. But I'm going to look at my leg, and you may have to open up a little bit, or center back. I can center back a little bit. Make sure that you have all the popliteal area included, and that you have all of the patella included. Which you can kind of see. You really can't see the other side on this. But check to be sure you see all the popliteal area included, that you haven't clipped that, and then you should see the lower leg coming off. Put my marker up in the light field. Okay. And so that's it. You'll do those 4 projections. Okay. Look at the knee, make sure it's in the light field good, that you're just including everything. A lot of times there's not great and wonderful single places to put those crosshairs. You just have to kind of make sure it's all included. And that's what you do, those 4 projections. So not too bad. Like I said, we are in the buggy now, so just keep in mind that you've got to make sure everything's lined up and that you're locked in transversely.
Will we have anatomy on the machine?
Yes, and yes. There will be knee anatomy. I think she got films pulled out today. And so there'll be anatomy of the knee, which there's not a ton of things on the knee really, but there is anatomy of the knee, and then you'll shoot a knee projection as well. So, okay. I guess.
Okay.
Unless y'all have any questions.
You can put space on.
Bye-bye.